Hello, and welcome to Disability 101, Intro and Etiquette. My name is Matthew Berwick, and I'm the Senior Program Manager, Disability Accommodations for Clinical Services at UPMC. I also serve as a disability advocate on local, state, and national issues. This presentation is on the basics of disability studies and history, including background, etiquette, and an overview of functional conditions. Our goal is to better understand people with disabilities as people, so we can better understand how to use assistive technology to meet their needs. If you're watching this, you might already have experience in this area, but all situations are different. You might be a wheelchair expert, but know much less about learning disabilities, for example. This presentation can help identify which areas are your strengths or weaknesses to make sure your knowledge of assistive technology is broad as it is deep. Research from the CDC found that 1 in every 4 American adults are living with some form of disability, meaning they've reported serious difficulty in at least one of these areas: mobility, cognition, independent living, hearing, vision, or self-care. In total, that's more than 60 million Americans. These numbers emphasize the need for us to better understand the lives of people with disabilities and promote inclusion and accessibility. These numbers also demonstrate that many disability conditions are comorbid, meaning that more than one condition often presents itself in the same person. These situations can be extra complicated and require us to be extra vigilant to our clients' needs. Interestingly, although the wheelchair is typically used as a symbol for accessibility, a majority of people with disabilities are not wheelchair users. Many disabilities are invisible, but that does not mean that these individuals cannot benefit from assistive technology. Let's have a quick look at how disability has been viewed throughout history. In the pre-modern era, before the advent of modern science, disability was often seen as a moral failure. People with disabilities and their families, especially those born with congenital conditions, were often thought to be punishments from God or a higher power. Disability was hidden away and was associated with shame. Despite the antiquity of these views, unfortunately, many of these attitudes still persist today. People with disabilities face stigma and are treated as outsiders to society. In the Enlightenment era, attitudes moved into what we call the medical model. In a way, this was a step forward, as the model positioned disability as having medical roots rather than moral ones. However, the model's thinking was entirely defect-based. Disabilities were wrong, and they were something that needed to be fixed. Rather than seeking accommodations or inclusion, the only solution to an individual with a disability was to outright cure the condition. Some theorists even went as far as claiming that medicine would eventually cure all disabilities, essentially advocating for the removal of disability from society entirely. However, medicine functionally did the opposite of this. As medical technology and procedures advanced, people continued living longer. People also began surviving conditions that would have been previously fatal, including congenital conditions affecting newborns or traumatic injuries affecting soldiers. This and other movements pushed attitudes towards people with disabilities to evolve. The civil rights movement in the 1940s, 50s, and 60s influenced the disability rights movement, and landmark pieces of legislation like the Rehabilitation Act of 1973, which fought for the rights of people with disabilities as a community. These thoughts evolved into the social model, which is the framework for disability studies most frequently used today. This model asserts that medical impairments in and of themselves are not disabilities. Instead, disabilities are the phenomenon created by impairment when combined with various barriers. These barriers can be institutional, like laws and policies, environmental, like physical spaces we inhabit, or attitudinal, like fear, discrimination, and lack of understanding that face people with disabilities. Thus, by working to remove barriers and provide accommodations, we can mitigate the overall impact and presence of a disability. It's worth noting that the social model is not without limitations or critics, nor is it the be-all, end-all of disability theory. However, it's the model largely used for assistive technology provision today. Criticisms include vaguely ableist language, which aligns with the defect model by viewing impairments as deficient. Also, the need to consider intersectionality and other barriers or roots of discrimination. It is not intended to be the end or final model and should continue to evolve. Another helpful tool for understanding disability conditions is the ICF framework, or the International Classification of Functioning, Disability, and Health. Like the social model, the ICF framework demonstrates how health conditions alone are not enough to understand a disability condition. Instead, we need to consider body functioning and structure, the activities the individual would like to do, their participation in daily life, and both environmental and personal factors. The ICF framework might just look like a bunch of arrows and words, but later in the course, we'll learn how this and other models can ensure that assistive tech practitioners like us can best understand the entire client and context in order to best meet their needs. So what can we do? Let's take another look at the 3 types of barriers put forth in the social model and how we can work to remove them. Institutional barriers can be removed through advocacy and lobbying to promote legal rights for people with disabilities. We can also change our professional practices to make sure we're inclusive towards people with disabilities every day. Environmental barriers can be removed with physical measures, like wheelchair ramps to bypass a flight of stairs, or other technology measures like providing written documents in alternative format for people who are blind. We can also accommodate people through assistive technology. Learning the best way to do this is the main focus of the ATPrep course. Finally, let's talk about attitudinal barriers. Though attitudes have greatly changed in the past decades, these barriers may still be the most difficult to overcome. Next, we'll talk about how the way we speak can change people's attitudes and how being mindful of etiquette can make the world more accessible. So let's talk about etiquette. First, we'll cover the basics, and then on the next slide, we'll talk more about clinical situations you may encounter. Most importantly, always see people as people, and not their condition. When talking to someone, talk to them, not their caretaker, companion, or interpreter. Don't make assumptions, especially about someone's condition or function, based on what you see. When in doubt, it is usually best to ask someone if they need any accommodations. Ask if someone would want your help before assuming. Then ask how or what accommodations you can provide. But you don't need to ask why. In a casual setting, don't ask what is your disability or what happened to you. Make sure you're sensitive about physical space and contact as you would with anybody else. Individuals who use assistive devices like wheelchairs often see these as extensions of themselves. So don't touch someone's assistive device or push someone's chair unless you're asked to. Finally, remember to be patient. This will go a long way in improving communication and making situations less awkward. You don't need to fill every second of silence with more words or questions. When you're working as a clinician or practitioner, it's worth noting that the dynamic between us and our clients might change. The same principles of dignity and respect apply, but we naturally might need to get more personal than would be appropriate in a public setting. First, it's important to build trust with your client. You can do this by treating them with dignity and respect as you would anyone else. And even though their appointment may be for a medical purpose, you're still seeing them as a person, not just their diagnosis. Listening to your client's concerns and answering questions will go a long way in building that rapport. Once you've built the trust up between yourself and the client, it'll be much easier and more appropriately to address the personal aspects of a clinical setting. In your assessment, you may need to ask private questions, touch a client's assistive device, or touch the individual themselves. Always ask your client's permission before doing this, and make sure you have and maintain professionalism. Challenges of confidentiality and ethics may arise. For example, if an individual with a unique speech pattern has a family member assist them with communication, this could violate the client's confidentiality. Or writing down health information to communicate with a deaf client could present a privacy risk. Individual professions have their own specific guidelines to help ethically and legally navigate these situations, which we will not go into today. For now, just remember that it is our responsibility to hold the client's wants and needs as the highest priority. Terminology and how we speak is a big part of etiquette and affects our attitudes and how we think. Person-first language is a great way to center on the individual you're speaking with rather than their condition. For example, an individual is not a quadriplegic, but instead a person with quadriplegia. Generally, don't overthink terminology. For example, common idioms like, "it's good to see you," or "did you hear about," are typically fine in casual conversations. Treating the person with the disability like any other person is more important than something like word choice. But we can talk about a few words and phrases to avoid. One such word is handicap, which comes from the antiquated stereotype that people with disabilities were unfit for employment and instead needed to panhandle for money with cap in hand. In practice, you can almost always replace that word with accessible, such as saying accessible entrance or accessible parking. Another phrase to avoid is referring to people who use wheelchairs as wheelchair-bound. This implies that the device itself is an obstacle, when in reality, the chair empowers the individual to be independent. Other things to avoid are terms that are obviously negative, like calling someone a victim or suffers from a condition, as this labels them as deficient, and avoid antiquated terms like retarded or crippled. You may also have come across newer terms like differently abled or handicapable. These terms mean well and may even be preferred by some individuals. However, without knowing for sure, it's typically best to avoid them. They can be confusing and excessive, and often draws unnecessary attention to the person who wants to be treated equally. These terms may also contribute to the objectifying of people with disabilities by labeling them as inspirational objects rather than people. In the end, there's no one correct answer for all terminology. There's just really good guidelines. When in doubt, ask, and always respect someone's preferences. Next, let's talk about different functional conditions. Think back to the social model and the ICF framework, and remember how they were less concerned with specific diagnoses and instead were more interested in holistic function and context. This is how we generally approach assistive technology. For example, if two individuals both have multiple sclerosis or MS, we wouldn't approach their situations in the same way just because they have the same diagnosis. Instead, we look at each of their functional capabilities, which combines their disease progression, environment, and activities the individual wants to participate in. In the next few slides, we'll investigate different conditions, then discuss etiquette and basics for working with people with those conditions. First up is mobility disabilities. This includes individuals who use power or manual wheelchairs, but also devices like canes, crutches, and walkers. As with all conditions, never make assumptions. For example, some wheelchair users can walk and use their chair to prevent fatigue or relieve pain from standing. In casual settings, it's not important exactly why they use their device, but it is important to understand that they may use this device for reasons that are best for them. It's also good practice to always keep the path of travel clear, especially in businesses or on sidewalks. When speaking with a seated individual who uses a wheelchair, consider the effect of eye contact. Pulling up a chair always allows the conversation to be held at the same level. If one isn't available, take a step backwards so you aren't towering over someone. And don't squat down because you aren't talking to a child. Other things to be aware of include surface heights and individual reach limits. Individuals who use wheelchairs might not be able to reach things on tables, or their grip strength might not be strong enough to pick things up. If handing something to an individual like documents or other items, it doesn't hurt to ask them how they would like it to be handed to them, or if you can place it in their backpack or somewhere else on their wheelchair. A common misconception about individuals who are blind is that they have no vision at all. Legal blindness is actually defined as having 20/200 vision or worse, or having a field of vision of 20 degrees or less. You've probably seen a Snellen chart like the one in the eye doctor's office. 20/200 is actually the largest letter at the top. So someone with legal blindness would actually not be able to see the letter at the very top from 20 feet away. This also takes into account accommodations. So someone with worse than 20/200 vision with the naked eye might not be legally blind if wearing glasses improves their vision enough. When working with an individual with disabilities of vision, keep in mind that it might not be obvious. Not everyone uses a white cane to walk, and someone may have very good visual acuity, but only in very limited fields of vision. Always introduce yourself by name when speaking to somebody who is blind or has low vision, and identify yourself when you leave the room as well. In a group setting, take extra time to introduce everyone who is present so no one is caught off guard by an unfamiliar voice. If you're in a new location or a familiar place with a layout change, it's helpful to give the individual a tour and point out new things that might be in that area. When guiding someone or giving them a tour, you can offer them to take your arm and walk the space together. Point out obstacles like a hallway if it becomes narrow or you're passing through a doorway. Slow down and announce steps before descending a curb. Use the clock face method and make sure that you're pointing out obstacles like the elevator, which would be 3 steps away at 3 o'clock, meaning that it is directly to your right, or our classroom is down the hall at 11 o'clock, meaning that it is down the hall and slightly to the left. You likely already know that service animals are working and should not be touched while on duty, and an individual should never be separated from their service animal. Finally, always have alternative for written materials, such as electronic documents that a screen reader can read, but consider accessibility apps and websites, as not all electronic formats are accessible to others. Now let's talk about the deaf and hard of hearing community. First, with some general guidelines. Always face the individual that you're speaking to and talk directly to them, not the interpreter or their companion. Speak clearly, but you do not need to shout, and ensure that you face them in case they are reading lips. Unless asked, it is generally not appropriate to interpret through a companion or family member. These roles are different from a formal interpreter, and you may have to consider confidentiality and privacy in these situations. The capital D deaf community is also different from the hard of hearing community or the lowercase d deaf community. Members of the deaf community identify themselves as having their own culture and as a linguistic minority. This group of individuals do not identify their deafness as a medical condition. Terms like hearing loss or hard of hearing may be offensive to the capital D deaf community. As always, don't make assumptions about individuals' community preference or their identity or how they communicate. Some individuals who are deaf or hard of hearing do not use American Sign Language and may not be appropriate to use interpreters with this individual. When working with individuals with speech disabilities or who are non-speaking and use alternative forms of communication, it's extremely important to be patient and don't just smile and nod if you don't understand. Make sure to give that individual your full attention, especially in group settings. If necessary, you can ask for further clarification or to try other communication methods so long as you are giving that individual the appropriate amount of time and attention. Don't just jump in when you think it will be easier. It can make things awkward and you may not understand fully what that individual is trying to say. Finally, just because someone's speech may be affected does not mean that they have other conditions. Unfortunately, there is a perception and stereotype that individuals with speech disabilities have a lower level of intelligence. As always, it is inappropriate to make assumptions like this. This next slide is about intellectual disabilities. Remember, we're talking about functional presentations, not specific diagnoses. In some ways, there are countless reasons or diagnoses explaining why someone uses a wheelchair. There are also countless reasons why someone might have an intellectual disability. In general, an intellectual disability is characterized by impaired intellect and adaptive functioning. This can, but does not necessarily include, things like task planning, memory, learning, and living independently. When working with someone with an intellectual disability, use simple, concise language, but not baby talk. Minimize distraction, and it can sometimes be helpful to break instructions into smaller tasks. Never assume that someone is or is not able to read, and in some cases, it may be appropriate to write things down. In some cases, it may be appropriate to try repeating yourself with a slightly different phrasing. When using slightly different phrasing, make sure you aren't overwhelming the person with extra filler words or speaking just because you're uncomfortable and trying to fill sentences. As always, patience is key. Learning disabilities may be conflated with intellectual disabilities, but in this case we're referring to conditions that affect individuals' ability to process and express information. For example, dyslexia affects how the brain reads words and letters, dyscalculia affects processing of math and numbers, and dysgraphia affects writing and spatial reasoning. Unsurprisingly, we can navigate these disabilities by presenting information in different ways, such as speaking information aloud when someone has difficulty with reading. Autism is another condition that is often grouped with intellectual and learning disabilities. Individuals with autism may have difficulty with social skills, self-regulation, and communication, and may be non-speaking. Things like direct eye contact and distracting noises may be uncomfortable for someone with autism. So minimize distractions and remember that if an individual isn't looking directly at you, it does not mean that they're not necessarily listening. When communicating, be clear and literal and avoid idioms and sarcasm. There are stereotypes that people with autism possess either savant-like intelligence or that they have a low level of intelligence. As with any stereotype, they can be harmful. please never assume that an individual's intelligence is based on what we see or what we think. Psychiatric conditions are another area that is poorly understood and where there is plenty of stigma. These can also be difficult to quantify, explain, or categorize. The important part is that as professionals, we recognize everyone's condition as valid and remain goal-oriented. Right now, you may not be thinking about how something like depression would impact your provision of assistive technology. But think back to the ICF framework, then consider how all of these conditions interact to create a full picture of the individual and their context. Some of these conditions listed below are pervasive, while others may have specific triggers. Having a baseline of understanding and awareness is essential in providing the best care. Many disabilities, including those on the previous slide, have hypersensitivities and triggers. These can range from asthma attacks being triggered by smoke, to a migraine headache being brought on by sensitivity to light, to a PTSD episode being brought on by a phobia or social setting. In addition to being aware of specific triggers that an individual client may experience, we can also be prepared for unexpected ones. For example, clinics can use unscented soaps and sprays in their restroom, or softer lighting to be mindful of our clients.